Welcome students. In my last lecture on anal canal, I was talking about the blood supply of anal canal. Now let me again repeat about it. The arterial supply of anus as you know is divided into three parts. Upper 15 millimeter forms the upper part, then our next 15 millimeter is called the middle part, and the lower 8 millimeter is called lower part. So these are the three parts in which anal canal is divided. It is supplied by arteries: superior rectal artery, inferior rectal artery. Veins: venous drainage is by three. One is the upper 1/3 part. It is drained by superior rectal plexus. So these are superior internal plexus which are going to, this plexus is going to be drained by the superior rectal vein. The middle 1/3 is drained by the external plexus. So external venous plexus, it drains into the systemic circulation. So this external, internal and external, there is a difference. This is going to drain into inferior mesenteric vein. Inferior mesenteric vein is going into portal vein, and thus this is going to, all the blood drained by this internal plexus is going to portal circulation, but the blood drained by external plexus, it is going into the systemic circulation. The lower part is drained by anal veins. Now there is a clutch here. This internal venous plexus is connected to the external venous plexus also. So this internal venous plexus and external venous plexus communication is actually the anastomosis between portal circulation and systemic circulation. So this is the site of, a very important site of porta caval anastomosis, means the blood from portal vein and the blood from the systemic circulation, they are connected here through this connection. Now this internal plexus, internal venous plexus, it is very prominent at three sites: 3 o'clock, 7 o'clock and 11 o'clock position. Apart from this, there are five more places, five more sites where it is prominent but less prominent. So we can call these three positions that I said, 3, 7 and 11 o'clock positions, they are the primary sites of hemorrhoids. So these are the hemorrhoidal sites. But the other five that I said, which are although less prominent, they are also sites for secondary piles. So this, you can see the three positions that I said, they can cause prolapse of the veins in those positions, and that prolapsed vein is known as internal piles. And in internal piles, patient will have no pain, he will not be aware of it, and he will keep on losing blood in his stool slowly without anyone coming to know of it. All you will know is a patient of anemia, chronic anemia visiting you. So in case you have any chronic anemia patient with you, at least do a simple test for occult blood in stool to know whether this is happening or not, and take proper history about his defecation habits, whether he is suffering from constipation or not, any kind of activity which will produce pressure during defecation, because all these are going to result into internal piles. As it is painless and it doesn't really give frank blood, patient will not be knowing about it. On the other hand, these anal veins which are present just subcutaneously, see, If a patient strains during defecation, some of the branches can rupture and they will form hemorrhage in the subcutaneous space, which will bulge out and it will be painful. So the patient will be very much aware from the first day itself, and he will come to the patient doctor immediately and will of course be cured. Usually the patients, they misunderstand only the external piles as piles and they don't take this internal piles into consideration. So you will have to explain it to them. Now, after this, I would like to tell you about the nerve supply. You have learnt about the arterial supply, venous supply, a little bit about the applied anatomy related to the venous supply. Now the nerve supply. The upper part is supplied by both sympathetic and parasympathetic nerve, but the lower part is supplied by the nerve which is have voluntary in nature, because this is the external sphincter and this is the internal sphincter. Internal sphincter is present only up to here and this is involuntary in nature, while this is external anal sphincter which is voluntary in nature, and in the lower part only the external sphincter is present. Now, one more very important landmark in anal canal is at the junction of rectum and anus. There is ampulla of rectum or rectum ampulla, and it is pulled anteriorly by puborectalis muscle. And to this puborectalis muscle, fibers are given off by this external anal sphincter as well as internal anal sphincter, and this ring should remain intact. If this ring is injured or cut accidentally during any surgery and not repaired, then the rectum will become incontinent, means there will be the stool will defecation can occur at any time. The rectum will not be able to hold it because it will lose its support. So lymphatic drainage, the one thing is left is lymphatic drainage. The upper part is going to drain in the inferior mesenteric lymph node, while the lower part is going to be drained in the superficial inguinal lymph node. This was all about the anal canal. Now a little bit about the applied anatomy. Applied anatomy, I have already said about the internal piles, the position of internal piles, 3 o'clock, 7 o'clock and 11 o'clock position. The external piles formed by the anal rupture of branches or tributaries of anal veins. Apart from this, you can see this line is the line of Hilton. So this line is actually in embryo or a developing fetus. It is covered by cloacal membrane. Initially it is cloacal membrane because in the initial period of development, urinary bladder and the hindgut are having the same opening called cloaca. Later on, a membrane, a septum is developed in between, and that is why this digestive system remains posteriorly, while the urinary system, that means the urinary bladder, ureter and all those structures, they go, that means the exterior system, excretory system, it goes anteriorly. Then the membrane which is left covering this opening is called anal membrane. This anal membrane can persist in some newborns if the meconium is not released. Meconium is the first fecal matter produced by the infant after birth. It can be just before birth in the womb itself, it can be during birth, it can be after birth, at least within a day. But if it's a black colored stool. If it is not passed, then the parents are definitely going to bring it to the doctor. You have to look at the area of anal opening there. If this is covered by a membrane, that is called anal membrane. Anal membrane, whenever it is present, it is also associated with stenosis of anal canal. That means the anal canal is very narrow. It is usually associated. If only the anal membrane is present, the treatment is easy. You can give a cruciate incision, have 4 flaps, and you can cut them very easily. But if the anal stenosis is present, dilatation is done. Sometimes the anal canal is not formed there. There can be agenesis of anal canal. There can be agenesis of rectum. So it will depend on the variety degree of the disease. It is not a disease basically. You can say it's a congenital disease, not an acquired one. So all these things can be present. I think you have understood all about the anus. You have understood about the applied anatomy. See so many diseases which you should know, which are common. Some present congenitally, some you will gain because of the wrong habits. So you have to explain to the patient, and you take him into confidence, and definitely the patient will understand what you're saying and take that proper treatment. So even though the anus is very small, just 3.8 centimeter long, present below the perineal diaphragm, but still it is a very important organ. I think you have understood it. Thank you.